Welcome, curious minds, to The Deep Dive. Today we're tackling a topic that's complex but incredibly important for anyone in healthcare, especially if you're heading towards the front lines of mental health. Our mission: to give you a really clear, kind of structured shortcut through a key chapter in Varkarolis's Foundations of Psychiatric Mental Health Nursing. We're zeroing in on the 8th edition, specifically the chapter on schizophrenia spectrum disorders.
That's exactly right. Think of this as grabbing the most vital nuggets of knowledge from that dense text. We'll try to, demystify some of the tricky terminology and connect everything back to your role as a future nurse, highlighting those absolutely essential NCLEX priorities along the way.
Perfect. So if you're a nursing student cramming for an exam, or maybe just curious about understanding one of the major mental health challenges out there, grab your metaphorical highlighter. Let's dive in.
Okay, so to kick things off, it's really crucial we understand this broad umbrella term, psychosis. Basically, it refers to altered thinking, altered perception, or an impaired ability to know what's real and what isn't. It's more of a symptom, really, not a diagnosis in itself, but it's absolutely central to the schizophrenia spectrum.
Right, and the chapter talks about a whole spectrum of disorders that share features with schizophrenia, but they're not quite the same thing. Could you walk us through some of those key differences?
Absolutely. Yeah, think of it like a continuum. So first up, you've got delusional disorder. Here, someone has delusions, these false beliefs, for a month or longer. But crucially, the delusions are often non-bizarre, like things that could technically happen, maybe being followed or someone famous being secretly in love with them. And their day-to-day functioning isn't usually severely impaired outside of that delusion.
Okay, so functioning is less impacted there. What about brief psychotic disorder?
Right, that one's different. It's a really sudden onset of at least one major psychotic symptom. So delusions, hallucinations, maybe disorganized speech, but it lasts more than a day and less than a month. And the key thing, a full return to their normal level of functioning is expected afterwards. It's brief, that the name suggests.
Got it. And schizophreniform disorder, that sounds closer to schizophrenia.
It is very similar symptom-wise. The main difference is the duration. Here, the symptoms last less than 6 months. Sometimes social or job impairment isn't even obvious yet.
Okay. And then there's schizoaffective disorder. That sounds like a mix.
Exactly. It's like schizophrenia symptoms happening at the same time as a major mood episode, so depression or mania. It's a continuous illness where you have both the psychosis and the significant mood component concurrently.
That's a lot to differentiate.
Right.
And you mentioned something critical earlier. One of the very first things a nurse needs to rule out when someone presents with new psychotic symptoms?
This is absolutely #1 priority. You always have to rule out substance-induced psychotic disorder or a psychotic disorder due to another medical condition. Is it drugs, alcohol, a prescribed medication, toxins? Or is it a medical issue like, say, delirium, a neurological problem, liver disease, thyroid issues? You have to check for those underlying physical causes first, because treating that is the priority.
That makes total sense. Okay, so let's zoom in on schizophrenia itself now. The chapter mentions it often starts gradually, maybe between 15 and 25. What does that typical clinical picture look like?
Yeah, for most people, maybe 75%, it does develop gradually. There's often what we call a prodromal phase. This means you see milder symptoms popping up months, sometimes even years, before a full-blown psychotic episode. Think subtle shifts. Maybe their grades start slipping, they withdraw socially, seem a bit more forgetful, or their speech is just odd. Recognizing this phase is so important for early intervention. But for the actual diagnosis, the critical piece is that the person must have at least one core psychotic symptom, hallucinations, delusions, or disorganized speech that's severe enough to really disrupt their life, impacting school, work, relationships, even basic self-care.
And the DSM-5 criteria, I know students can find that diagnostic and statistical manual section a bit overwhelming. Can we simplify the must-haves?
Definitely. Think of it like a checklist. For a schizophrenia diagnosis based on DSM-5, you need 2 or more of those active phase symptoms like delusions, hallucinations, disorganized speech, grossly disorganized behavior, or negative symptoms present for a significant chunk of time within a 1-month period. And here's the kicker. At least one of those symptoms has to be delusions, hallucinations, or disorganized speech. Plus, you need to see a real drop in their level of functioning work, relationships, self-care. And these continuous signs of the disturbance have to persist for at least 6 months. And like we said, you've got to rule out schizoaffective disorder, depressive or bipolar disorder with psychotic features, and of course, substance or medical causes.
Okay, that clarifies it. The chapter also mentions epidemiology affects all cultures equally, but maybe diagnosed a bit more in males. But those comorbidities, they really jumped out at me. They seem quite significant.
Oh, absolutely. They are incredibly common and really complicate the picture. Nearly half, maybe 40–50%, struggle with substance use disorders, especially alcohol and marijuana, and that unfortunately tends to worsen the prognosis. And nicotine dependence is huge, maybe 60% or more. There's some thought it might be a form of self-medication, which we can touch on later. Anxiety, depression, and suicide are also extremely common. The suicide rate is tragically about 5 times higher than in the general population. Nurses really need to be vigilant about suicide risk, especially after that first psychotic episode or upon discharge.
Wow. And it's not just mental health comorbidities, is it?
No, not at all. People with schizophrenia have much higher rates of physical illnesses too, things like cardiovascular disease, diabetes, respiratory issues, and they die, on average, about 20 years earlier than the general population. This is often linked to things like poor health habits, maybe difficulty accessing care, side effects of meds, and sadly, sometimes stigma within the healthcare system itself. And one more, less common but potentially lethal one to watch for, polydipsia. That's compulsive water drinking. It can lead to fatal hyponatremia, dangerously low sodium. As a nurse, if you see a sudden worsening of psychosis, maybe confusion or delirium, you need to consider hyponatremia.
Okay, that's critical to know. Let's shift gears to risk factors. It's interesting that the book emphasizes it's likely a group of disorders, not just one single thing. What's the leading theory on causes?
The main model we use is the diathesis stress model. Basically, it suggests an interaction between genetics and environment. So biologically, genetics plays a major role. It's estimated to account for maybe 80% of the risk. If you have a first-degree relative, your risk goes way up. Then there are neurobiological factors. The dopamine theory, suggesting too much dopamine activity in certain brain areas, is a big one, but it's more complex than just that. Serotonin, glutamate, GABA, acetylcholine, they're all likely involved too.
And what about the brain itself? Can we actually see differences?
Yes, quite often. Brain imaging studies like CT, MRI, PT scans frequently show structural abnormalities. Things like reduced volume in certain areas, maybe the hippocampus or prefrontal cortex, deficits in gray matter. This points towards potential issues in how the brain developed or maybe problems with neural pruning, the process where the brain trims unnecessary connections as it matures.
So biology is key. What about the stress part of diathesis stress?
Right, the psychological and environmental factors. These are thought to trigger the illness in someone who's already genetically vulnerable. We're talking about things like prenatal stressors, infections during pregnancy, maybe paternal age, psychological stressors like major life stress, trauma, maybe even the stress of going off to college can sometimes trigger a first episode. Stress increases cortisol, which isn't good for the brain long term, and environmental stressors, exposure to certain toxins, living in urban areas, chronic poverty, migration, all these have been linked, so it's really this complex interplay, not just one cause.
Definitely not simple. Okay, and what about the prognosis and phases of the illness? Does everyone follow the same path?
Not at all. The prognosis varies hugely. Many people with good treatment can improve significantly and lead really fulfilling lives. But certain factors tend to predict a less positive outcome, like a slow, insidious onset starting very young, or a longer period before getting treatment. More negative symptoms also tend to mean a tougher course. Relapse prevention is absolutely key to improving those long-term outcomes.
And the phases you mentioned.
Right. The illness typically progresses through 4 phases, though it can vary. First, the prodromal phase, those early, mild, often vague symptoms we talked about, social withdrawal, maybe some odd thoughts. Then the acute phase. This is where the symptoms become really prominent and disabling, florid hallucinations, delusions, disorganized thinking. This is often when someone first gets hospitalized. After that comes the stabilization phase. Symptoms start to decrease in intensity, moving towards their previous baseline. Medication helps stabilize things here. And finally, the maintenance or residual phase. The condition is relatively stable, positive symptoms are often much reduced or absent, but negative and cognitive symptoms might persist. The focus here is on recovery, maintaining function, preventing relapse, and quality of life. But yeah, recurrent exacerbations are common. It's usually a chronic illness needing ongoing management, kind of like diabetes or heart disease.
All right, let's really dig into the nursing role now. Assessment, that's always foundational, isn't it? Where do we start?
Assessment is everything. It's about gathering data comprehensively. You need to interview the patient, carefully observe their behavior, and crucially, talk to family or others who know them well, because the patient might not be aware of their symptoms, or they might try to hide them due to paranoia or stigma. Building trust and using strong therapeutic communication skills is essential right from the start. You'll do a standard mental status exam, but you also need to look broader to assess their spiritual, cultural, biological, psychological, social, and environmental context. And remember that prodromal phase early assessment focusing on risk factors and coping skills can actually be preventative. The text even mentions some early research on things like omega-3 fatty acids, potentially helping in the at-risk stage.
Okay, now for a really critical part for students, especially for the NCLEX. The chapter breaks symptoms down into four main categories: positive, negative, cognitive, and affective. Can you really help us nail down the differences between these? This seems fundamental.
Absolutely fundamental. Mastering this is key. Let's break it down. Positive symptoms. Think of these as adding something to the person's experience, things that shouldn't be there. They're often the most noticeable or dramatic symptoms. This includes alterations in reality testing. The person struggles to tell what's real. Under this, you have delusions. These are false, fixed beliefs that don't change even with evidence. Common types include persecutory, feeling plotted against; referential, believing neutral events have special meaning for them; grandiose, inflated sense of self-worth; erotomanic, believing someone, often famous, is in love with them; nihilistic, convinced a major catastrophe will occur; somatic, beliefs about bodily functions or appearance; or control, believing thoughts, actions are controlled by an outside force. Super important note, beliefs that are part of someone's culture or religion are not delusions. You need cultural competence here.
Okay, so delusions are false beliefs. What else falls under positive symptoms?
Alterations in speech. This reflects disorganized thinking. You might hear associative looseness, where ideas shift illogically from one topic to another, like the example in the text. I need a Band-Aid. My friend was talking about AIDS. Friends talk about French fries, but how can you trust the French? See how the connections are loose. Or word salad, which is just a jumble of words that makes no sense. Throat horse strength policy dreadfully. Clang associations, choosing words based on sound, like rhyming rather than meaning. On the track, have a Big Mac. Click, clack. Neologisms, made up words that only have meaning to the patient. Ecolalia, repeating another person's words pathologically. Other patterns include circumstantiality, giving excessive detail but eventually getting to the point. Tangentiality, wandering off topic and never getting back. Cognitive retardation, slowed thinking. Pressured speech, rapid, urgent speech. Flight of ideas, rapidly shifting topics. Symbolic speech, using symbols instead of clear communication, like demons are sticking needles in me for pain. Thought blocking, sudden stop and thought. Thought insertion, belief thoughts are put in their head. Thought deletion, belief thoughts are taken out. Magical thinking, believing thoughts or actions cause things. And paranoia, irrational fear.
Wow, that's a lot of ways thinking can be disrupted. What about perception?
Right. Alterations in perception. Errors in how they interpret sensory input. Hallucinations are the big one here. Sensory experiences without any actual external stimulus. Auditory, hearing voices, are the most common. Then visual, seeing things. Olfactory, smell. Gustatory, taste. And tactile, touch are less common but can happen. A command hallucination, where a voice tells the person to do something, especially something harmful, is a psychiatric emergency. You must assess for this immediately due to the risk of harm to self or others. Then there are illusions, which are misinterpretations of real stimuli, like seeing a coat on a hook and thinking it's a person, or mistaking rustling leaves for voices. Also, depersonalization, feeling unreal, like you're observing yourself from outside, and derealization, feeling the environment has changed or isn't real.
Okay, so beliefs, speech, perception. What's the last category of positive symptoms?
Alterations in behavior, changes in movement or illogical actions. This includes catatonia, which is a significant increase or decrease in movement. It can range from stupor, no movement, to excitement, agitation. A classic feature is waxy flexibility, where the person maintains a position they're placed in, like a mannequin. You might also see motor retardation, slowing down, or motor agitation, pacing, restlessness, stereotyped behaviors, repetitive actions without purpose, echopraxia, mimicking others' movements, negativism, resisting instructions, impaired impulse control, odd gesturing or posturing, and boundary impairment, difficulty sensing where their body ends and others begin.
That's a really thorough breakdown of positive symptoms, the additions. Now, what about negative symptoms? You said these are often the tougher part.
They really are. Think of these as subtractions, the absence or reduction of things that should be there, like normal motivations, interests, or expressions. They're often less traumatic than positive symptoms, but can be more persistent and debilitating for functioning and quality of life. They're harder to treat with medication, too. The chapter uses the 6 A's, which is a helpful way to remember them. Anhedonia, inability to feel pleasure from things they used to enjoy. Avolition, lack of motivation or ability to initiate tasks. Big impact on self-care. Asociality, decreased interest in social interaction and relationships. Affective blunting, reduced intensity of emotional expression. Their face might seem flat or unchanging. Apathy, decreased interest in activities or beliefs. General indifference. Alogia, reduction in speech output, sometimes called poverty of speech. Brief, empty replies.
The 6 A's, that's helpful.
Right.
Okay, third category, cognitive symptoms. How are these different from, say, disorganized speech?
Good question. While disorganized speech reflects thought process, cognitive symptoms relate more to thought content and overall intellectual function. They involve problems with thinking, memory, attention, and judgment. A key one is concrete thinking. This is the inability to think abstractly. They interpret everything literally, like the classic example. You ask, what brought you to the hospital? And they say, a cab, instead of explaining their symptoms. Or if you use an idiom like, the grass is always greener on the other side, they might take it literally and talk about lawn care. Assessing for abstract thinking, like interpreting proverbs, is part of the mental status exam. Other cognitive symptoms include impaired memory, especially working memory, impaired information processing, difficulty screening out stimuli, and impaired executive functioning. That's the higher level thinking needed for planning, problem solving, decision making, and self-control.
That really impacts daily life.
Yeah.
Okay, last one, affective symptoms.
Right. These involve emotions and their expression, basically mood. Mood might be unstable, erratic, labile, or just incongruent with the situation. But the big one here is depression. It's very common in schizophrenia, and it's a serious concern because it significantly increases the risk of suicide. Assessing for depression and hopelessness is critical. It can also be a sign that a relapse might be coming.
That's an incredibly useful framework. Positive, negative, cognitive, affective. So knowing all this, how does the patient's own insight, or maybe lack of insight, affect how we provide care? And what about our own feelings as nurses?
That's a huge challenge, anosognosia. It's the inability to recognize that you're ill, and it's caused by the illness itself, by the brain damage. It's not denial in the psychological sense. It's a neurological symptom. And it makes it incredibly difficult for someone to accept treatment or see the need for help. Understanding this can really change how you approach someone who's refusing meds or seems uncooperative. It's not willful defiance, it's part of the illness. And yes, self-assessment for nurses is vital. Working with psychosis can be stressful, maybe even frightening at times. It's really important to be aware of your own feelings, anxieties, or maybe even biases, and talk about them with supervisors, peers, or faculty. Managing that countertransference is key to providing objective therapeutic care.
Good point. So to wrap up assessment, could you give us a quick checklist of the absolute must-dos?
Sure. Your general assessment checklist should always cover: rule out medical or substance causes first, absolutely first. Conduct a thorough mental status examination, appearance, behavior, speech, mood, affect, thought process, thought content, perception, cognition, insight, judgment. Assess for hallucinations in detail. What kind? Content. Are they command hallucinations? Triggers. Coping strategies. Remember how to ask, what are you hearing, not what are the voices saying? Assess delusions. Content. How strongly held? Is there paranoia? Any risk of harm based on the delusion? Critically, always assess for suicide risk. Ideation, plan, intent, means, history. Assess their ability to ensure personal safety and health. Nutrition, hydration, sleep, hygiene, safety awareness, impulse control. Are they dressing appropriately for the weather? Evaluate their current medications. What are they prescribed? Are they taking them? Adherence. Any side effects? What factors affect adherence? Cost, mistrust, anosognosia, stigma. And finally, assess the family's knowledge, support system, and response to the illness. As the text highlights with the example of stigma in some cultures, like the Chinese family seeing it as punishment, cultural competence and family education are vital. You need to help them understand it's a brain illness.
Okay, assessment complete. Now we move into nursing diagnosis and planning outcomes. How does that work?
So based on your assessment data, you formulate nursing diagnoses. These target the patient's specific problems. Common ones might be disturbed sensory perception for hallucinations, disturbed thought processes for delusions, risk for violence, self-directed or other-directed, impaired verbal communication, self-care deficits, social isolation. The list goes on. When setting outcomes, you always want to align with the recovery model. This model emphasizes hope, living a full life despite the illness, not just symptom management. Outcomes need to be specific, measurable, achievable, relevant, and time-bound SMART goals, and they should be tailored to the phase of the illness. In the acute phase, outcomes focus on safety and stabilization. For example, patient will consistently label hallucinations as not real by day 3, or patient will refrain from self-injurious behavior during hospitalization. In the stabilization phase, outcomes might focus on understanding the illness, adhering to medication, and developing coping skills. Patient will identify 3 triggers for relapse by discharge. And in the maintenance phase, outcomes center on maintaining stability, independence, quality of life, and relapse prevention. Patient will attend support group meetings weekly.
Makes sense to tailor it to the phase.
Yeah,
And planning follows from that.
exactly. Planning involves deciding how you're going to help the patient achieve those outcomes. Again, it's phase dependent and considers the patient's strengths, needs, and cultural background. In the acute phase, planning often involves ensuring safety, maybe hospitalization, initiating medication, managing crises. In stabilization and maintenance, planning focuses much more on patient and family education, teaching skills, coping, social, self-care, connecting them with community resources like ACT, assertive community treatment teams, NAMI, support groups, vocational rehab. A huge part of planning, especially long-term, is relapse prevention. Nurses played a key role in helping patients identify their personal early warning signs of relapse, things like changes in sleep, increased worry, feeling overwhelmed, maybe isolating more, developing a written plan for what to do when stress increases, like who to call, coping strategies to use, reinforcing medication adherence, avoiding drugs, alcohol is incredibly important. Each relapse can potentially worsen long-term function.
Okay, planning is set. Let's talk implementation, putting the plan into action. The chapter uses that case study of Don, the 42-year-old veteran. Can you walk us through how a nurse, let's call her Sarah, like in the text, might actually talk to and intervene with them? This seems like a great way to see therapeutic communication in practice.
Great idea. Okay, so Don comes in, he's got auditory hallucinations, voices tell me things, paranoia, someone's trying to kill me, a history of substance abuse, suicidal thoughts, I should die, and even past assaultiveness. He's guarded, avoids eye contact, mumbles. So Nurse Sarah approaches him. Her goal is to establish trust and begin assessment in a non-threatening way. Expert speaker, as Nurse Sarah. Don, my name is Sarah. I'll be your nurse while you're here in the hospital. If it's all right with you, maybe we could meet each day for about 20 minutes. We can talk about whatever concerns you have. Establishing role, offering time, patient-centered focus.
And Don replies, kind of deflecting, well, don't believe what they say about me. I want to start. Are you married? Testing boundaries, maybe paranoia. Expert speaker, as Nurse Sarah. This time is set aside for you, Don, to talk about your concerns. Gently redirecting back to the patient, maintaining professional boundaries. He scans the room, looks down, then says quietly, I think someone is trying to kill me, expressing a persecutory delusion. Expert speaker, as Nurse Sarah. You seem to be focusing on something else right now, not quite in our conversation. Making an observation about his nonverbal behavior, gently probing without directly challenging the delusion yet. Then Don admits, voices tell me things, I should die. Revealing command hallucinations and suicidal ideation, critical information. Expert speaker, as Nurse Sarah. That sounds very upsetting, Don. Tell me more about what's happening. I want to understand so I can try to help you. Expressing empathy, validating his feeling upset without validating the hallucination itself, opening the door for further assessment of the voices and suicide risk.
So you see, in that short interaction, Sarah uses several techniques. She establishes rapport, sets boundaries, redirects, makes observations, expresses empathy, and focuses on his experience without agreeing with the content of the psychosis. She focuses on the here and now and his feelings. For Don, key nursing diagnoses would likely include altered thought processes, risk for suicide, risk for other directed violence, and maybe non-adherence if he stops meds due to paranoia or side effects. His care plan goals might be, Don will report auditory hallucinations to staff. Don will state he knows the voices are not real. Don will remain safe and not harm self or others. Interventions would involve building trust consistently, assessing those command hallucinations frequently, exploring triggers, teaching coping strategies like reality testing, can others hear the voice, or using competing stimuli, music, talking, and educating him about his illness and medications. For non-adherence, you'd explore why he's resistant to side effects. Paranoia at anosognosia, convey empathy, and try to link taking medication to his personal goals, like wanting to keep his job or stay out of the hospital. It's very patient-centered.
That example really brings it to life. Beyond Don's specific case, are there some general nursing interventions for common problems we see in schizophrenia, maybe based on that table 12.3 the chapter mentions?
Yes, that table is a great resource. Let's hit a few common ones. Poor hygiene self-care deficit. Break tasks into small, manageable steps. Use visual cues or checklists. Praise efforts. Connect good hygiene to benefits the patient values, like feeling better or peer acceptance. Resistance to treatment medication, non-adherence. This is huge. First, build trust. Explore their concerns without judgment. Are they worried about side effects? Do they not believe they're ill? Anosognosia. Try to tie treatment to their goals. Taking this medicine might help you focus better so you can keep your job. If they're suspected of cheating, hiding pills, discuss switching to liquid or a long-acting injectable LAI form with the provider. Anosognosia. Remember, you can't argue someone into insight. Don't directly challenge their lack of awareness. Instead, focus on building trust and finding common ground on the symptoms that are distressing to them, e.g., it sounds like not sleeping is really bothering you, even if they don't connect it to the illness. Peer support specialists who've been there can sometimes be very effective. Avoiding social interaction withdrawal. Approach in a calm, accepting manner. Offer brief, frequent interactions focused on neutral, low-anxiety topics. Offer opportunities to join groups, but don't pressure them. Sometimes activities like pet therapy can be a great, non-threatening way to engage. Depression, hopelessness. Actively convey empathy and hope. Validate their feelings. It sounds like you're feeling really down. Help identify small, achievable goals. Encourage stress-reducing activities like exercise, mindfulness, or engaging in pleasant activities, even small ones. Risk for violent suicide, always top priority. Assess risk factors. History of violence, paranoia, command hallucinations telling them to harm someone. Increasing anxiety agitation. Implement safety measures. Closer observation, removing dangerous objects. Ensuring medication adherence. Use de-escalation techniques first if agitation occurs. For suicide risk, maintain constant vigilance. Assess for warning signs, sudden calm after depression, giving things away. Implement safety protocols, 1.1 observation, contraband checks, and establish a safety contract if appropriate, but don't rely on it solely.
Okay, that's incredibly practical. Let's drill down a bit more on specific therapeutic communication techniques for those core positive symptoms. Hallucinations, delusions, and that associative looseness.
Right. How you talk to someone experiencing these symptoms is key. For hallucinations. First, watch for cues, eyes darting, muttering, seeming distracted. Ask directly but neutrally. Are you hearing something? Or what are you hearing? Not what are the voices saying, which implies they're real. Crucially, do not argue about whether the voices are real or not. Don't say there are no voices. Instead, offer your perception and acknowledge their distress. I don't hear any voices, but I understand that's frightening for you, or that sounds very upsetting. Validate the feeling, not the experience. Try to focus them on reality-based activities or conversations. Let's focus on our discussion here. Help them identify triggers, like stress, and learn coping techniques. Using competing auditory stimuli, listening to music through headphones, talking to someone, humming, reading aloud, reality testing, ask trusted others if they hear it, and managing stress.
Okay, so validate the feeling, offer your perception, focus on reality. What about for delusions?
Similar principles, but tailored to beliefs. Again, build trust that's foundational. Avoid debating the content of the delusion. Arguing almost never works and can damage rapport. Instead, gently express doubt where appropriate, especially if they're starting to question it themselves. I find that hard to believe, or that seems unusual. Validate any part of the delusion that is based in reality. Yes, there was a man at the nurse's station, but I didn't hear him talking about you. This is called finding the kernel of truth. Focus on the feelings or underlying themes the delusion might represent. If someone has grandiose delusions of being powerful, you might reflect, it seems like you wish you had more control in your life right now. This addresses the underlying emotion. You can gently clarify reality. I know you believe the FBI is monitoring you, but I don't see any evidence of that here on the unit. Again, try to refocus the conversation onto reality-based topics and activities.
So don't argue, focus on feelings, gently reality test. What about that really disorganized speech, like associative looseness?
When thinking is that fragmented, communication is tough. First rule, never pretend you understand if you don't. That's dismissive. Instead, place the difficulty in understanding on yourself. Say, I'm having trouble following what you're saying right now, rather than, you're not making any sense. Try to pick out recurring themes or topics, even if the connections are loose. It sounds like you've mentioned your family several times. Summarize or paraphrase what you do understand to model clearer communication and check your understanding. And when you speak, keep your own communication concise, clear, concrete, and use shorter sentences. Avoid abstract language.
That's really helpful advice.
Right.
Okay, shifting to health teaching and promotion. How important is involving the family here?
Oh, incredibly important. Families are often the primary support system, but they're also deeply affected by the illness. They need support and education, too. Teaching should cover the illness itself. It's a brain disease, not a character flaw. Treatments, medications, therapy, recognizing early signs of relapse, effective coping strategies for both patient and family, medication information, purpose, side effects, adherence, and available community resources. Programs like the National Alliance on Mental Illness, NAMI, Family to Family Education Program are invaluable. They provide information, skills, and crucial peer support for families. Educating the family reduces their anxiety, helps them understand behaviors or symptoms, not laziness or manipulation, and empowers them to be partners in care. Like that parent quote in the text, realizing it was her illness changes everything. They become secondary consumers who also need care and support.
Absolutely. Okay, let's move into the major treatment modality, psychopharmacology. Medications are usually essential, right? What's the overview nurses need?
Yes, antipsychotic medications are a cornerstone of treatment, especially for positive symptoms. They've dramatically improved outcomes since the 1950s. We generally talk about two main generations, plus a newer one, first-generation antipsychotics, FGAs, also called typicals or conventional antipsychotics, or sometimes neuroleptics. Examples include haloperidol, Haldol, and chlorpromazine, Thorazine. They mainly work by blocking dopamine D2 receptors. They are quite effective for positive symptoms, hallucinations, delusions, disorganized thinking, but they come with a higher risk of certain side effects, especially movement-related ones.
Okay, and the second generation.
Second-generation antipsychotics, SGAs, also called atypicals. This group includes drugs like clozapine, clozaril, risperidone, olanzapine Zyprexa, quetiapine Seroquel, Bursidone, Geodon. They work a bit differently, blocking both serotonin, specifically 5-HT2A, and dopamine receptors. Generally, they treat positive symptoms effectively, and they often have some benefit for negative symptoms too, which FGAs usually don't. They tend to have a lower risk of those FGA-typical movement side effects, but they come with their own set of significant side effect concerns, especially metabolic ones.
And you mentioned a third generation.
Yes, third-generation antipsychotics, TGAs. The main example is aripiprazole, Abilify. Brexpiprazole, Rexulti, and cariprazine, Vraylar, are also in this class. These are sometimes called dopamine system stabilizers. They act as partial agonists at D2 receptors, meaning they can increase or decrease dopamine activity depending on the baseline level. They also affect serotonin systems. They aim to have good efficacy with potentially fewer side effects, including less metabolic risk than some SGAs and less EPS than FGAs. One key thing about all antipsychotics, they don't work instantly. It usually takes about 2 to 6 weeks to see significant improvement. Patient education on this is vital for adherence.
And what about formulations? Are there options besides pills?
Yes, and this is important for adherence. Many antipsychotics come in liquid forms or fast-acting orally disintegrating tablets, ODTs, which can help if a patient is cheeking or has trouble swallowing pills. Even more significant are the long-acting injectables, LAIs. These are given by injection every few weeks or even months, depending on the specific drug. LAIs are a fantastic option for patients who struggle with daily adherence, as it takes that burden off them and ensures consistent medication levels. It dramatically reduces relapse rates for many people.
Okay, let's talk side effects because nurses are constantly monitoring these. What are the big ones for those first-generation antipsychotics, FGAs?
The major concern with FGAs is extrapyramidal side effects, EPS. These are movement disorders caused by the dopamine blockade in motor pathways. There are several types. Acute dystonia, sudden, often frightening, sustained muscle spasms, usually in the head and neck, like neck twisting torticollis or eyes rolling up oculogeric crisis. This is an emergency requiring immediate treatment, usually with an anticholinergic medication like benstropine, cogentin, or diphenhydramine, Benadryl, akathisia. A really distressing inner restlessness and inability to sit still, pacing, fidgeting. Patients describe it as feeling like they're jumping out of their skin. It can be mistaken for anxiety or agitation, but it's a drug side effect. Needs careful assessment and management, often by reducing the dose or adding another medication. Pseudo-Parkinsonism. Symptoms that mimic Parkinson's disease. Tremor, especially pill rolling. Muscle rigidity, like cogwheel rigidity. Shuffling gait, drooling, mask-like facial expressions. Slowed movement, bradykinesia. Usually managed with anticholinergic drugs or by lowering the antipsychotic dose. Tardive dyskinesia, PD. This is the most serious EPS because it's often persistent and can be irreversible even after stopping the drug. It involves involuntary rhythmic movements, typically of the face, mouth, and tongue, lip smacking, tongue protrusion, chewing motions, grimacing, but can also affect limbs and trunk. Nurses must routinely screen for TD using standardized scales like the Abnormal Involuntary Movement Scale, aims. Early detection is key. There are now specific treatments approved for TD, like valbenazine, Ingrezza, and deutetrabenazine, Ostida.
Wow, EPS sounds like a major issue. What other side effects do FGAs cause?
They can also cause anticholinergic side effects, dry mouth, blurred vision, constipation, urinary retention, tachycardia, sedation, orthostatic hypotension, dizziness on standing up, and sometimes hyperprolactinemia, hyperlactin levels leading to things like gynecomastia or menstrual irregularities due to dopamine blockade in another pathway.
Okay, so lots to watch for with FGAs. What about the second-generation antipsychotics,
Uh-huh.
SGAs? You said less EPS, but other concerns?
Exactly. While generally causing less EPS, though akathisia can still occur and some SGAs at higher doses have more EPS risk, the big concern with many SGAs is metabolic syndrome. This is a cluster of issues. Significant weight gain, especially around the abdomen, dyslipidemia, high cholesterol and triglycerides, and insulin resistance or hyperglycemia, which increases the risk for type 2 diabetes. This is a huge health risk, increasing cardiovascular disease rates. Clozapine and olanzapine tend to have the highest risk. Nurses play a critical role here in monitoring weight, waist circumference, blood pressure, glucose, and lipids, and providing intensive health teaching about nutrition, exercise, and lifestyle changes to mitigate these risks.
Metabolic syndrome is a major one then. Any other key SGA side effects?
Yes, a granulocytosis, a potentially fatal drop in white blood cells, specifically neutrophils, is a rare but serious risk, most strongly associated with clozapine. Because of this risk, patients on clozapine require mandatory weekly blood monitoring, checking absolute neutrophil count, or ANC, for the first 6 months, then biweekly, then monthly. It requires a strict protocol and registry system. Other potential SGA side effects include sedation, especially with clozapine, olanzapine, quetiapine, orthostatic hypotension, anticholinergic effects, though often less than FGAs, QTC interval prolongation, a heart rhythm issue, and sometimes seizures, particularly with clozapine. Or sexual dysfunction can also occur.
A granulocytosis with clozapine, that's a critical safety point. Are there any other really dangerous antipsychotic side effects across the board that nurses absolutely need to recognize as emergencies?
Yes, definitely. Besides acute dystonia and granulocytosis, there are a few others. Anticholinergic toxicity. This is a potential emergency, especially in older adults, or if someone takes multiple anticholinergic meds. Symptoms can include delirium, confusion, flushing, dry skin membranes, mydriasis, dilated pupils, fever, hyperpyrexia, tachycardia, urinary retention, unstable vital signs. Critically, it can look like worsening psychosis, so careful assessment is vital. Requires holding anticholinergic drugs and supportive care. Neuroleptic malignant syndrome, NMS. This is rare but life-threatening, associated with any antipsychotic, though maybe more with high-potency FGAs. Key features are severe muscle rigidity, lead pipe rigidity, very high fever, hyperpyrexia, altered mental status, confusion progressing to coma, and autonomic dysfunction. Unstable BP, tachycardia, sweating. Requires immediate stopping of the antipsychotic, intensive supportive care, cooling, hydration, and often medication like dantrolene or bromocriptine. QTC prolongation. Several antipsychotics, like ciprasidone, haloperidol, thiordazine, carry a risk of prolonging the QTC interval on an ECG, which can lead to a potentially fatal arrhythmia called torsades de pointe. Requires baseline and periodic ECG monitoring, especially if there are other risk factors. Liver impairment. Some antipsychotics, particularly older FGAs like chlorpromazine, can potentially cause liver injury. Requires monitoring liver function tests, LFTs.
NMS and anticholinergic toxicity, definitely need those on our radar. Okay, let's circle back to something we mentioned earlier, that high rate of nicotine use. The chapter references a study, Improving Attention with Nicotine. What was the takeaway there for nursing?
Right. That study highlights the observation that people with schizophrenia smoke at incredibly high rates, maybe 3 times the general population. One hypothesis is that they're self-medicating, particularly for the cognitive deficits like attention problems associated with the illness. The study suggested that nicotine did seem to temporarily enhance attentional performance in individuals with schizophrenia. So what does this mean for nursing practice? Well, obviously we can't encourage smoking because of all the terrible health consequences. Smoking cessation is still the goal. However, it does raise the question of whether nicotine replacement therapy, like patches or gum, might have a dual benefit, helping with smoking cessation and potentially offering some cognitive support as an adjunct treatment. But it's complex. We also need to remember that smoking induces the metabolism of certain antipsychotics, like clozapine and olanzapine, meaning smokers might need higher doses. If they suddenly stop smoking, like during hospitalization, their drug levels could rise, increasing side effect risks. So monitoring smoking status is important for medication management.
That's a really interesting clinical implication. Now, the chapter briefly touches on advanced practice nursing roles and other therapies. What does those involve?
Advanced practice registered nurses, APRNs, with psychiatric specialization play a crucial role. They can provide individual, group, and family psychotherapy using modalities like cognitive behavioral therapy, CBT, which is very effective for psychosis in helping people manage delusions and hallucinations. They conduct psychoeducation, manage complex psychopharmacology, perform comprehensive health assessments, and provide consultation. Some APRNs also specialize in cognitive remediation therapy, which uses targeted exercises, kind of like brain training, to help improve cognitive functions like memory, attention, and executive functioning that are often impaired in schizophrenia.
And you mentioned family therapy.
Yes, family therapy and psychoeducation are hugely important interventions, often led by APRNs or other therapists. Families experience immense stress, stigma, and burden. Family therapy helps improve communication patterns within the family, teaches problem-solving skills related to managing the illness, lowers levels of expressed emotion, criticism, hostility, which can trigger relapse, and provides essential support and education. It really aims to make the family an ally in the treatment process, recognizing them as those secondary consumers who need support just as much as the patient. That NAMI quote again about understanding it's the illness, not laziness, that's the kind of shift family therapy and education can facilitate.
That seems vital for long-term recovery. Okay, wrapping up, how do we evaluate progress and ensure we're providing high-quality care?
Evaluation is ongoing. We need to regularly reassess the patient's symptoms, functioning, and progress towards their goals. It's important to remember that progress in schizophrenia can be slow and sometimes erratic with setbacks. So celebrating small steps and incremental improvements is key. Setting those realistic, achievable goals helps. Consistent staff involvement, active collaboration with the patient, even when insight is limited, and family involvement, all aligned with that recovery model, are crucial for building trust, motivation, and treatment adherence or buy-in. For quality improvement, nurses need to ensure care is evidence-based. Are we using effective medications and monitoring them properly? Are we consistently assessing for suicide risk and substance use? Are we actively working to prevent and manage metabolic side effects? Are we addressing medical comorbidities? Are we using tools like the AIM scale regularly? Are we providing psychoeducation? Ensuring coordinated care, maybe through assertive community treatment, ACT, or case management, and promoting access to self-help and support groups like NAMI are also key quality indicators.
Wow, that really was a deep dive. We've covered so much ground, from understanding the spectrum of psychotic disorders and the nuances of positive, negative, cognitive, and affective symptoms, all the way through assessment, communication techniques, the complexities of psychopharmacology and side effects, and the importance of family and recovery-oriented care.
Absolutely. And understanding these concepts, it's not just about memorizing facts for your NCLEX, although that's important. It's really about building the foundation of empathy, critical thinking, and the practical skills you'll need every single day when you work with individuals experiencing these incredibly challenging illnesses.
As your guides here on the deep dive, we really want to thank you for sticking with us and immersing yourself in this material. You're not just gaining knowledge points. You're genuinely building the groundwork for providing compassionate, effective, and knowledgeable mental health nursing care.
So as you go forward, here's something to think about, maybe a provocative thought. How might truly understanding that anosognosia, the lack of insight, is often a neurological symptom of the illness itself, rather than just stubborn denial, fundamentally change your approach? How might it change how you try to build rapport, foster trust, and advocate for patients who seem resistant to accepting the help they need?
We hope this deep dive has empowered you on your nursing journey. Until next time, keep learning, keep asking questions, and keep making that vital difference.